the onyx in the fistula side, in the sigmoid sinus, and I worked my way back until I got to the areas where both the ascending pharyngeal was supplying and the middle. So the middle meningeal and ascending pharyngeal were supplying two different parts of the sigmoid sinus. So there were two different fistulous points. So initially, when we started the procedure, we couldn't really appreciate the middle meningeal as well because the ascending pharyngeal was the more robust one. But once I embolized this, the middle meningeal became a lot more apparent. So I just had to keep pulling my catheter back through the sigmoid sinus and keep injecting onyx till it took down the draining vein.
What viscosity was it, 18 or 50?
No, usually, so onyx is 18 and 34. This was 18 because 18 has better chances of penetrating into the fistula. Yeah. But now there's a lot more liquid embolic. So you have onyx, which is 18 and 34. You have fill. You have the glue. And the good thing about glue is you can make it at any concentration you like. You can make it very fast, or you can make it very dilute. So I use glue for my middle meningeal artery embolization. So I use like a 5-to-1. So five parts of the oil and 1 part of glue. That makes it travel farther. If you want the glue to just come out of your catheter and quickly embolize or quickly just coagulate, then you use like a 1-to-1. So like 1 of iodol and 1 of glue. All right. And then so this entity I'm sure you see all the time is oops. I think we're stuck here. Sorry. Give me 1 second. But the next slide I'll show you when it comes up is I'm sure you see a carotid cavernous fistulas here all the time, right? And so when I started training, pretty much the only option to treat CCF. So let me ask you, how do you treat CCF here?
It was just carotid ligation when it was in the early 19th.
Yeah.
Would do the carotid ligation.
Right.
Now it is referred to endovascular.
Right. And what does endovascular do, Saima? Right. Right.
But really the balloon embolization is very famous there.
Yeah. So, sorry, give me 1 second. I think my computer just or the presentation just crashed. So we'll build it up. So yeah, so essentially that's what you do, right? So in a direct CCF, you have a hole in the artery, and it's a big enough hole, and the blood is pouring out in the cavernous sinus. They're losing vision. The blood's getting out into the superior ophthalmic vein. So yeah, so we try to do transarterial, transvenous. Some people would put like a bunch of coils in the venous in the cavernous sinus, and now more recently we have started putting pipeline devices, because then hopefully it will cure. But the problem with the pipeline is not a completely covered stent. It's only 30% metal. 70% is still porous. So as long as if it's a big hole and there's a big high flow gradient from a high pressure to a low pressure environment, it will continue to stay open, and it's not going to stop. Give me 1 second, because I think I really need to show you this. So now, just maybe last year, I was talking to, I think this is the beauty of interdisciplinary care. Right? So I was talking to some of the cardiology folks, and more recently, and so I was talking to them, and I'm like, why can't we use it as CCF fistula? And shortly thereafter, this patient shows up, and I took him to the angiography suite, and I had to apply for, humanitarian exemption device and all that stuff with the FDA that you have to do. And I put that device up, and look at that. Like the hole's gone. His artery looks completely normal, right? So with this just one stent, you take care of it. Whereas, you know, with other modalities, you have to keep putting coils in and balloons and this and that. This took like literally 15 minutes. You go up the balloon mounted stents. So once you position the stent in a good position, you inflate the balloon. As the balloon inflates, it expands the stent. The stent hugs the wall. You deflate the balloon and you just pull everything out and you're done. And it's that easy, right? So yeah, so that's pretty much that. All right, so moving on, cerebral revascularization. So right, so very good question. So routine stents. So let's say, so in neuro, we have predominantly three types of stents. So one is the one that you use for stent-assisted coiling. So an example of that is an Atlas stent that Stryker makes, or Elvis Junior stent that Microvention makes. They are just open cell stents. So like it's almost like this, like braids like these, right? So there's a lot of space. So the metal coverage is like maybe 5%. So there's minimal metal amount. It's just basically, if you look at it, there's a lot of porosity. Like we can, if you have to coil the aneurysm, let's say even if you put the stent, your coiling catheter can go through the stent into the aneurysm. So there's plenty of space. So that stents are mostly just for providing a support and scaffold.
It's a mesh.
Not exactly. It's just like some wires put together in this configuration that sort of expand and collapse together, right? The next is flow diversion, which is more like a mesh, so to speak, but the metal coverage is still about 30 to 40%. It's not complete. So there's still holes, but they're very, very, very tiny holes. So you cannot get your wires or catheters through it. So once you put a flow diverter across an aneurysm, you cannot get into the aneurysm. There's no way you can get into the aneurysm, right? So yeah, so if you have to coil an aneurysm and pipeline it, you have to put the catheter behind your pipeline. So you can coil it and then put your pipeline device. But still, it's 30%. That's why you do not want to put, I mean, you can put pipelines in across, let's say, anterior choroidal artery, because it doesn't go down. The demand keeps it open. You can put it across ophthalmic artery. The ophthalmic artery usually typically will not go down. Some people now have put the pipeline across in MCA bifurcation. So if you have two branches and you have an aneurysm, you can put the pipeline in one. The other one will stay open for a long time, or over time, because of distal collaterals, will slowly go down and shut down, but the patient will not get a stroke. So it will allow the blood to flow through it. And the third stent, the papyrus or the covered stent, has no porosity. So it's a stent that is completely covered with this material called PTFE. So the PTFE is like almost like a sheet. Someone like chadar hai, wo lapet diya, it's like a cylindrical water pipe that we use in our PVC, right? But obviously not the same material. So if you put that across a perforated segment, like lenticular striatum across, the ophthalmic, anterocoroidal, that will shut down like right away. It's a completely covered stent, right? So in the cavernous segment, you don't have any critical branches, right? So, but for CCF, you have to close the hole. That works perfectly, right? Because it's a covered stent, blood cannot get through it. Aapne bas ek dafa dal diya, it just shuts it down and you're done. But the patient needs to be on dual antiplatelets for about 6 months. Yeah. Ji.
We've done one case with the Excalibur device.
Okay.
That is also by the Merlin. That is also a very mounted stent.
Yeah.
With this sheet.
With the sheet, yeah, PTFE, yeah. Yeah.
With one device.
Yeah, no, I mean, all you need is one device. Yeah, all you need is one device. That's all you need. If you properly size it, it works beautifully.
And this device is now being used for this CCF management.
So it's not approved for it. It's an off-label use. The only indication for that is right now. जो अभी फिलहाल जो approval है वो it's only for cardiac people for coronary perforations, right? So because they apparently get perforations all the time, especially if it's a really hard plaque and whatnot. And we're working towards getting it approved. So right now I'm a part of this registry. We're collecting cases across the country. Once we have enough cases, then we can apply for, because it's not, CCF in our part of the world are not super common. We're trying to go for this, what's called a humanitarian device exemption, where it's not completely on label, but to use it, we don't have to fill out the paperwork. So like when I had to use this, I had to like fill out a bunch of paperwork, and the people came back to me from FDA, said, okay, well, do you have any other good option? Can you pipe coil it, this, that? And, you know, I had to do through all those acrobats to be able to use this device.
That would be sort of trial.
So this will lead to a trial, yes. This will lead to a trial, exactly, for outcomes and whatnot, yes. So cerebral revascularization, quickly going through it, you know, you just have to supply blood to the brain if the original sources are exhausted. Most of the time we use STA, but rarely occipital artery or interposition graft like radial artery, and now more commonly we're doing an intra-arterial to intra-arterial. So like, you know, you don't have to take an extracranial donor and just use an intracranial donor. So predominantly use it for either for flow preservation or for flow augmentation. So flow augmentation is like, let's say somebody has moya disease, and obviously they're getting symptoms of TIAs and strokes and whatnot. You can augment their blood flow by taking STA, or in flow preservation, if you have to really sacrifice a blood vessel for aneurysms, then you have to like preserve the flow. Then you do like mostly high flow bypasses. As I said, mostly it's for moya diseases. So this is a normal angiogram to your left. A moya angiogram looks like that, right? You know, the distal ICA terminus looks bad, and you have all these hypertrophied lenticular striate vessels that are essentially the moya vessels, right? And so, do you do it here commonly? STMCA bypasses or no?
No.
Okay. So maybe I'll just spend a little bit more time here. So it's actually not a very difficult procedure. It is technically challenging, but once you practice it enough times, it's not terribly difficult. So the idea is essentially you take a superficial temporal artery, you harvest it from the skin, and then once you do the yes.
In I think 1980, have a PCI bypass. I prefer,
Ji.
but you know, the load of the German neurosurgical work is so
much.
large.
Right.
So you cannot do this undertaking for hours, and you can find hours and
Right.
hours. So we did not, continue.
No, I think that's because trauma, tumors, AVM aneurysm, that's way more common than this disease. I completely agree, and I think this should only be done in specialized few centers. Like even in the US, not every center is doing bypasses, right? So they're like a handful number of centers, because if you don't do them routinely and you don't have enough practice, then you're right, it will take you like 8 or 10 hours. But if you do it routinely, like I remember when I first did my first bypass, it took me like 6.5, 7 hours. But now, alhamdulillah, we have trimmed the time down to like 3 to 4 hours, right? So it's still a lot of time, but there we still have the luxury. The load is not as bad as.
And we started this learning upon defects.
Yeah, I started on rats. Yes, yeah. So exactly. So it's a graded learning pattern, and then once you find the MCA branch, you basically just revascularize it. So here's a. Do we have time? Can I just show a short video, Dr. Fazia? Okay. So I think this one is important because since as Dr. said, we don't do it. So you just have to under the microscope or under loops, you just find that STA. So you can see the STA right there, thumping right there. And then you move it to the side, you do your small craniotomy, you can open the dura, and then see if you can find a recipient, right? So if you find a good, like right there's a good MCA branch right there, right? You put a background material. There's a lot of preparation because you want to keep the field dry and so on and so forth. And then you basically make an arteriotomy. So you put clips on the MCA so it doesn't bleed, obviously. And then you open the MCA, and then you just basically take these are 10-0, or I use 9-0 or 10-0 sutures. And then you stitch the SCA to the MCA. Now, obviously, with video editing and everything looks very clean, but trust me, it's not always like that, right? So it's a lot of editing makes it look nice and dry and whatnot, but every now and then there's blood and all that stuff coming in. And then even sometimes you can do the best of job, but sometimes if you accidentally grab an extra layer, it will occlude your aneurysms, occlude your bypass. So you have to open the whole thing again and then redo it. So it's a painstaking. It's only like basically putting a stitch and tying it. That's which you guys have done millions of times, but it's just done on a much smaller scale. And so once you take the clips off the vessel, then you reestablish the flow in the MCA. And then after that, you take the clip off the STA, and that should take care of and then and so then once you do that, before surgery, this is one of my patients with moya before surgery, and then after surgery, you can see this STA right there, right here, that supplies right here coming up. It looks so big, and then it's plugged with the MCA, and you can see the whole MCA debris being supplied now. So, and obviously ischemic symptoms get better. And then, rarely, as I said, you can do it for aneurysms. The Fadi Charvel in Chicago talks about this flow probe. I sparingly use it, to be very honest. But it helps you to determine the flow before and after the occlusion of the vessels and how much of a bypass would you need. I'll probably skip Elena as well because. So this is something that I wanted to show you, right? So this is where I think, for me, my surgical skills come together. So this is a dissecting pica aneurysm in sort of the second segment of pica, right? But you saw the big thrombosed aneurysm on the MRI. The actual aneurysm or the part that's filling on the angiogram is just this little fusiform thing. So obviously it was causing compression of the brainstem. So endovascular was really not an option here. So we decided to take her to the OR. I did a far lateral craniotomy. And then what I did was we basically just cut the proximal and distal pica from the aneurysm. It's from the large aneurysm itself. And so there's a distal end of the pica cutting off. And then there was enough redundancy. So there's enough length that you can work with. So you bring the two ends of the pica together. Okay, so you can reestablish the flow in pica so they don't get a pica stroke, which people recover from, but it's not pleasant to have Wallenberg and not be able to swallow for like 6 to 8 weeks or a few months. And you see, as soon as you open the clips, there's established flow in the pica right there, right? And so right there, you can see the pica looks nice and reconstructed. You can do an ICG or intraoperative angiogram just to make sure that your bypass is open. This is a Doppler flow probe that we're checking the flow. Okay. And then this is the ICG that shows that there's robust flow through the pica. And once that is done, right, now I can get into the aneurysm because now aneurysm has no blood supply. You get into the aneurysm and you can just evacuate the clot as much as possible and then decompress the brainstem. So I think microsurgery is here to stay. Some people think, oh, with endovascular microsurgery will go away. I think these cases like these will have to be done. So great question. So does everybody understand the question? Yes. Okay. So two things. So my belief is that if I'm doing an endarterectomy on somebody, they will have like severe critical stenosis. So if somebody has severe critical stenosis, they already have really good collaterals that they have developed through different sources. So if somebody is stenosed 99%, and if I'm clamping them and making them 100%, their brain should not be like, it's not like I'm taking a completely normal artery and I'm clamping it down, right? So that's one thing. Two, I raise their blood pressure by 20 to 30 points when I clamp them, so I can promote the flow across the ACOM and PCOMs. And I put them on a propofol bolus so I can burst suppress them. Three, we use this thing called the cerebral pulse oximetry. So it's a very simple device. You put them on their forehead, and then it gives you the oxygen concentration on both the right and the left hemisphere. So before I open the carotid, I'll clamp the carotid and I'll wait for like a minute or two. Typically, oximetry will show me changes like within 20 seconds if there were to be any changes. So if I don't see any changes, then I'm good to go. But I will keep the Shabra shunt on the table all the time. So it is on my table all the time. But knock on wood, alhamdulillah, I've done about 50 to 60 in my last 2 years. I've not had to use it a single time. जी साहब. Common injection, but let me just, this is what's impressive, right? So you look at the MRI post-op, and this is a diffusion weighted image, right? And so you have few diffusion hits there, something in there, right there, right about there, and that's it, right? So instead of a massive whole hemisphere going away,
Time window.
so
Following, there is some variability.
right. So, for TPA, they talk about 3 hours and 4.5 hours. But more recent data that has come out for thrombectomy, we can do it up to 24 hours of last known normal. So let's say, God forbid, you knew somebody and you say, oh, I saw him at dinner at 9 p.m. and he was fine. So let's say, even if they had a stroke, let's say right after that time at 9:01 p.m., we are at about 12, 13 hours. We will still now, if we so we'll do a CT scan. If the CT scan shows that the whole hemisphere is not infarcted because it will gray out, we call it the aspect score. If the aspect score is reasonable, we'll still take him for a thrombectomy up to 24 hours. So yes, the time window is massive. It has the data has shown that up to 24 hours, if we do a thrombectomy, they will still do better than if you just leave them alone and leave the vessel occluded. Yeah.
What's the best time? What is the best time?
Best time is as soon as possible. So like I've had cases literally where we were in the ER or we were out there, in the ER looking patients, and somebody just dropped in front of our eyes, in the emergency bay, and we did a CTA, and we're like, oh, he's got an M1 occlusion, and within like, I would say 20 to 25 minutes of his symptoms onsets, we had opened his vessel. So there's no, like, the sooner the better, because every minute the vessel is occluded, you have millions of neurons dying, right? I don't exactly remember the number, but it's pretty impressive, like 3 million or something like that. So yeah, every minute counts. So we actually have this joint certification so stroke centers in the US are categorized by their performance. So the highest level is comprehensive stroke center. So my level is a comprehensive stroke center, but it's not easy because what they'll do is they'll come to us every 3 to 6 months and they'll look at our metrics. तो वो देखेंगे जी आपने door to needle time क्या था, door to puncture time क्या था, और your reperfusion time कितना था, इतनी देर क्यों लगी, and why did this happen, why did that happen, and if you're off your metrics by a lot, then they will ding you, they'll cite you, they might put you on probation, and they might take your comprehensive certification away. तो हमारे लिए बड़ा stressful है, तो रात के 3 बजे मुझे call आती है, तो when a neurosurgery resident calls me, it's subdural, then I'm like, okay, get started, I'll get there. So I know about it, and they get to the OR position, make the skin incision, and open the bone. I have time, right? In stroke, I have to get up and run. Like, I have no time whatsoever, because if the patient gets on the table, the clock starts ticking. Where is the surgeon? And why is the procedure not started? Fortunately, I have fellows and endovascular fellows, and they start the procedure and whatnot. And we do it all the time. I do like close to 300 thrombectomies a year. So my fellows get a lot of experience, but yeah, I mean, you don't have a lot of time, and it's a real emergency, right? We do. Yes, absolutely. No. So for almost all patients, will get a CT scan, a CT angiogram, and a CT perfusion. But the CT perfusion has problems with it, right? So if the patient is moving all over the place, which these stroke patients are, it's very sensitive to motion. So zara bhi move karega patient, the whole study is bad. So a lot of times we'll just go by the CT scan and then just see how much of the infarct has developed. If there's a little bit of infarct in the basal ganglia here and there, we'll take the patient. If the whole hemisphere is like just, stroked out, midline shift, or then obviously because reperfusing those people, you can cause massive hemorrhage, right? Reperfusion hemorrhage out there. But CT perfusion, yeah, you look at if it's a good study, then it will show you a core and the penumbra. When I started training, we were like, if the core is more than 50 or 60 cc's, that's too much, forget it. Now, just last year in 2023, these trials came out, which are called the large core trials. So they say even if the core is 100 cc, which is a lot of core, you still should take them because the outcome of those patients, if you open their vessel up, is still better than if you leave their vessel closed. And there are some centers who will just do a CT, CTA, will not do CT perfusion, and they'll take every patient regardless. Every patient. Reperfusion hemorrhage. So there are classes of hemorrhage. There's something called contrast staining, because sometimes these capillary beds open up and you see some contrast. That's not a real hemorrhage. If you're talking about just non-symptomatic, like a non-clinically significant hemorrhage, I would say that rate is about 20%. But there's a little bit of hemorrhage here and there you don't really care about. Symptomatic that you have to do something about is probably, I would say, 5 to 10%. Yeah, and you see that more in people who are delayed presenters, have already a big core, and I think I can tell in 80% of the cases that yaar, iska hemorrhage hoga, right? So I will counsel the family that I can open the vessel up, and we might have a hemorrhage that we might have to take him back to the OR and decompress him and so on and so forth. Yeah.
And you heparinize the patient.
Yeah, we just give 3,000 units of heparin. We don't like flood them with heparin. We just give 3,000 just so that catheters with clots. So it's like we heparinize the patient even for our angiograms and whatnot. So I just don't want any clot forming on the catheter and then that showering. So I'll just give them 3,000 heparin typically, not much.
What about this collapsing?
The what?
For this anticoagulation post-operative.
No, so it depends, right? So if somebody has a cardioembolic, like an atrial fibrillation, so then once you open the vessel up, if they don't have intracranial hemorrhage, the neurology or the emergency department will start them on some kind of anticoagulation 48 hours later. Yeah. So that they don't have recurrent hemorrhage.
Low molecular weight.
Yes. Enoxaparin.
Yeah.
Post-operatively? Yeah. I typically like to use enoxaparin in my spine patients. I do a lot of spine surgery too, that pays the bills. I typically try to use just unfractionated heparin for my cranial patients. Post-operatively. You're talking about DVT prophylaxis. Then?
There's a collapsing.
Yeah. No. For this procedure specifically, we put heparin in our flushes.
And that is how many units?
No, 3,000 the bolus hota hai.
Bolus to the patient.
To the patient, and then we put additional 3,000 to 4,000 heparin in our flushes. Yeah. Flush to bahut slow chalta. It's about 1 ml per minute or something like that. We just need to keep it dripping. If you stop the flush, the blood will back up into the catheter, will clot off, and it will, you're gonna next time run cutting it, the clot's gonna go into the brain. So you want to keep the catheter on the flush all the time.
Coming back to the carotid endoscopy, what are the chances of imparting the bigger stroke to the patient in expert's hands after this carotid endoscopy?
So if you look at the data, they say the risk of causing a stroke, a disabling stroke in any hands, and anybody who's doing an atherectomy in asymptomatic patients should be less than 3%. In symptomatic patients should be less than 6%. Now, that is based off the data, which is 20 years old. I think now those thresholds have even lowered. So somebody will, if you are getting 6% strokes in your atherectomy patients, I think somebody will come up and talk to you. I think now the realistic numbers are 1% and probably less than 3%. So 1% for asymptomatic, 3% for symptomatic. So I don't do any asymptomatic carotids because I don't believe atherectomy has a role in asymptomatic. Uski wajah ye कि the medical management has become so good now that you cannot justify putting people through revascularization without giving them the true trial of endarterectomy. So I will not do asymptomatic. If somebody has amaurosis, fugax, TIA, that's all symptomatic. So I will do those.
So the indication for surgery in carotid endarterectomy are now very limited.
Not really. I mean, you mean versus stenting?
Yes.
Yeah, no, so it really depends. So let's say I get a patient or you get a patient, you say, okay, well, you can offer them both. So the things I would look at is I would look at their anatomy first, right? So if it's a very high bifurcation, endarterectomy is out. If it's a good low bifurcation, okay, but if it's heavily calcified, then stenting is out, right? If somebody cannot take antiplatelets because they start bleeding from the stool or whatnot, stenting is out, right? If somebody is very high risk for general anesthesia, endarterectomy is out. So these are the 4 or 5 variables that I look at. Now, every now and then I'll get a patient who has a soft plaque or some calcification, low bifurcation, can take antiplatelets. So फिर उस सूरत हाल में I just tell them कि भाई आपके ये 2 options हैं. Do you want to do surgery or do you want to do stenting? And it's interesting. So you will think, well, if somebody will offer me stenting, I'll take stenting because there's no incision, this and that. Lekin interestingly, patients have this thing in their head that वो कहते हैं कि जी you're going to balloon, you're going to put a stent in, so all that debris is still going to stay in the artery. I'm like, yes, because you're going to just push it to the side. They're like, no, I want it cleaned out.
And what are the chances of carotid stenosis after carotid endarterectomy?
It's pretty low actually. It's really low. So there's a lot of things, right? So people have looked into this and they've reported rates up to 15 to 17%. But उसमें problem ये है कि we don't know what the native size of the vessel is. So a lot of times I'll see these patients who have these chronic strokes and occlusions, near critical stenosis. What happens is, depending on where the stenosis, let's say if it's at the bulb, if it's really severe stenosis and it's been there for too long, your distal carotid artery, that starts to become smaller in size. And the next thing you know, it's very, very small. So what happens is when you open that artery, do an endarterectomy, if you don't patch them, then you obviously, when you suture them up, so थोड़ी बहुत भी scarring होगी, that's going to lead to stenosis of the vessel. So what I don't know is that data, how much of that is clouded by that fact? Because I see a lot of these stroke patients because that's what I do. And it's interesting how these vessels will become smaller. So if somebody's distal vessel is small, also I will try to prevent endarterectomy. I'll probably say, we can do stenting, because in stenting you can angioplasty them and try to open them up a little bit more, right? But again, with stenting, there's risk of in-stent stenosis, right? Because of endothelialization and whatnot. So I think the risk for both probably lives around between 10 to 15%.
And when would you decide you would apply the patch graft while doing the carotid endarterectomy?
If the vessel is too small, like if I feel like if I'm suturing, you have to take those bites in the carotid at the Oh, so sometimes if it's a very fresh and friable, so some people will come to us in the ER, they're like within 3-hour window, they'll get a TPA, TKG, and then we'll bring them up to in this case. Endarterectomy, yeah. Yeah, no, I've not had to do that. No, I'm a big. Right.
But in my 22 to 23 years career, I have never seen a single case operated for AV fistulas.
Right.
I read about them for the first time when I was preparing for my FRCS, and I was surprised that the treatment of choice for the spinal AV fistula is the
Surgery.
excision, the disconnection of the venous
For
channel
type
from
1.
that.
For type 1,
And
yes.
the case you have presented here is extremely very nice. Just coagulate that petrosal vein,
Right.
and that is excellent.
Yeah. No,
So we must, I think this is this case opened our minds that many times in the posterior fossa we have bleed in the young patients, and we are searching behind whether the patient has bleeding disorders, patient is hypertensive or not, because I think, and for the first time, I feel that I must be very good in reading the angiogram, because unless if you are not good in reading the angiogram, your radiologist will report it's normal.
Well,
The
I think one
case
of
you
our
have shown.
patients this morning or
Yeah.
today had an angiogram reported normal, spinal angiogram reported normal, and we saw the AV fistula. So I'll tell you in my practice, and again,
Cases which you showed us, they will definitely be reported in our country as normal.
well, they were one of them. But I'll tell you this. So that's the beauty, right? So if you are trained, let's say you, even if you don't do the whole endovascular gamut, but सिर्फ अगर आप diagnostic angiogram पढ़ना और करना सीख लें, and I mean, no disrespect, but if other specialties, neurology, radiology, cardiology can do an angiogram, surgeons can do an angiogram, and it's very, very easy. Like I think if I had to teach somebody to do an angiogram, I can teach them just to do a normal angiogram in 3 to 4 months effectively. Angiogram becomes this like very, it's a holy grail, it's a big undertaking. I'll tell you, so to your point, which I think is a great point, if I have a young patient with a hemorrhage that I cannot explain, and when I say explain, I mean, या तो उसको सर पे किसी ने मारा हो, या गोली लगी हो, या कुछ, I will do an angiogram. I don't care what the CTA shows or says, I will do an angiogram. Why? Because once I can do it, so अब मुझे किसी पे dependent, मुझे हाथ जोड़ने की जरूरत नहीं अपने radiologist से कि यार please कर दो, so I don't have to do that. And then B, it takes me what, 20 minutes to do an angiogram? Less than that, right? So if you're quick, 20 minutes में आपने जी फटाफट vessels अपनी select की, angiogram किया, and you answer the question. You're like, na AVM and aneurysm and fistula. Then you're like, okay, now let's start looking for other causes because if the poor guy has actually a fistula. So I'll give you an example. I had this guy who came in from different state, and you know, I don't know, he got into trouble, got to jail. Jail में उसको किसी ने मारा पीटा. He came to us with some intracranial hemorrhage, and everybody said, oh, yes, जो है वो assault की वजह से हुआ है. So I was a neurosurgeon on call. I looked at the CT scan and I said, this is not a traumatic subarachnoid. This is something else fishy is going on. And do I have a few minutes? Can I show that case to you? Okay. So something is fishy is going on, and so I so we did an angiogram on this guy, and then Dr. Fauzi, look at this. So this is an external carotid injection, right? So this is AP, and this is lateral. The middle meningeal, and look at that. The middle meningeal is supplying this big venous spherix, and look at the size of the spherix, right? I mean, it is sitting there to rupture like of the massive hemorrhage. ठीक है जी. So now what are you gonna do? Or basically venous, छोटा सा, I don't know if you can see this thing. You got like a daughter aneurysm right here, right?
Yes.
So I mean, it's an extremely high risk for rupture. ठीक है. So I mean, so you can open his head up. Sure, I mean, you can open his head up. His middle meningeal is right here, right? And the vein is right there. So all you have to do is, you don't have to worry about this, but you have to basically take this is the fissure, right? You see this fissure, all this abnormal fluff and the vein. आप इसको surgically bust कर दें, you'll be done. What did I do? I mean, this middle meningeal for me is massive, right? I mean, this is a big middle meningeal. So I put the catheter all the way here. I injected onyx. It's done, right? Which is fine. I mean, so basically, before I did this case, we talked to our colleagues all the time. What do you think? So literally half of my department, जो मेरे neurovascular, we have 6 of us. 3 ने कहा कि surgically करेंगे, 3 ने कहा endovascular. So you know, this is a split. So there's no right or wrong answer. It's whatever you're comfortable with. So what I said, okay, well, I'll take the catheter, I'll inject onyx. If I kill it, great. अगर completely cure नहीं हुआ, I had the OR ready for backup. कि जी अगर नहीं हुआ तो I'm just gonna bring him down to the OR right from the angio suite, do the craniotomy. I'll see some onyx that will help me identify, and then I'll just clip it and resect it and be done with it.
You can CT brain showing the bleed.
Let me see. Not in this present. I actually presented this case at Link. Yeah, no, I don't have his CT scan right now. Sorry. Yeah, I presented this at our Link conference, the Endovascular conference.
मेरी पिछले दिनों में एक दोस्त से बात हो रही थी, तो जब भी बात होती है तो आप एक बन गया एक आखिरी क्वेश्चन होता है, that is robotics and the artificial intelligence.
Yes.
तो इसका जो है neurovascular surgery and endovascular interventions, वो क्या है?
At the moment, so I think that's a great question. So I can tell you, artificial intelligence has already come into this space, and I'll tell you how. So Dr. Saab here talked about CT perfusion, right? So back when CT perfusion became commonplace and thrombectomy became commonplace in 2013-14, what they would do is, let's say the patient, I'm just giving you a little bit of background so you'll see how AI has revolutionized stroke care at least. And it's even doing that here in Pakistan, and ICVD has it and so on and so forth in Karachi. So patients would come in with a stroke, we'll get a CT, CTA, and CT perfusion. Then the computer will process the CT perfusion. Then you call the radiologist after 3 baje. Please, they say you'll get up, he'll turn on his computer, he'll look at the CT perfusion, and kabhi karo baithe baithe so jaye computer pe, whatever. And then they'll get back to you आधे घंटे बाद कि जी हाँ ठीक है जी इसको perfusion penumbra है और इतना core है, you should do the stroke and whatever. And then a couple of softwares came into being, the AI softwares. So एक है this AI, एक है Rapid AI. Rapid is an Israeli technology. This AI, I think, from German or something. But उससे हुआ ये कि अब जो AI का software है, it's on my phone, right? So if a patient comes in with a stroke, जैसे उसका CT, CTA, CTP होता है, as soon as the CTP is done, the software, the artificial intelligence software will analyze the CTP, और उसको लगेगा कि there's a big penumbra and a favorable core penumbra ratio that thrombectomy should be done. वो software automatically मुझे और मेरे staff को जो on call होगा वो alert भेज देगा. So they have taken the neuroradiologist out of the equation. So somebody did a study on this. कि जी, how much time are we saving? People were saving across the country. People were saving up to 180 minutes. And 3 घंटे you were saving because of this AI software. तो वो 3 घंटे आप सोचें कितने कीमती हैं for every patient who is sitting there with an M1 occlusion. So to your point.
Thank you so much. So nice of you. A wonderful lecture, and sir, you are doing a great job. As we all know that spine is being taken over by the orthopedic surgeons, vascular is being taken over by the radiologists and neurophysicians, and pituitary is being now assisted by the ENT surgeons. So whatever left. We just have few gliomas to operate in the next decade. So the work which is being done by Dr. Akil is really a wonderful job. And the message from this lecture is that every neurosurgeon who is interested in the vascular neurosurgery, he or she must be trained with the endovascular as well, so that we can save this area for the next generation. Otherwise, we are off with only few gliomas. Thank you so much, and please proceed for the tea.
Thank you.